Okay, welcome to a recorded version of the stroke lecture that I gave for a 2025 update to the Rehab MDT in December of 2025 at the Walton. So let's begin with the definition of stroke. Now, this is a very clean World Health Organization definition. Rapid onset neurological deficit lasting longer than 24 hours. However, we don't just look at time anymore, we look at tissue. And that's because a huge proportion of TIAs now, we're finding that actually they have got tissue-based objective markers on scans that suggest that actually there's long-term neurological damage that has occurred. A big percentage, 30 to 50% of TIAs actually are misdiagnosed as TIAs, and they actually have got lesions on imaging that would have led to an intervention if they'd been seen. Okay, so time and tissue. Less than 24 hours, you're thinking TIA, but get imaging. MRI, DWI is the classic one. Now, when you look at the World Health Organization's mortality outcome studies, this is the data from 2021. The biggest killer in the world was ischemic heart disease, then it was COVID, because it was 2021. Third was stroke. Now, why is this important? And it's because the leading cause of disability in the long term and the third biggest killer in the world is stroke. Then you've got COPD, lower respiratory tract infections that aren't TB, which was 10th, and lung cancer. Now, this is really important when you look at it. The third leading killer in the world. So we really need to know a lot about it. You can't know too much about stroke. One of my favourite quotes, is from this architect called Louis Sullivan, and it's form ever follows function, which I'm sure you've heard of before. And this is the anatomy follows the physiology, or the pathophysiology, right? This is how we can classify stroke. Anatomy, where the lesion is, the syndromes that result, and then the function. So we can use this wonderful thing called the TOAST criteria. Now, the TOAST criteria comes from a study done in 93, Trial of Organisation 10172 in acute stroke treatment. And it was all about trying to classify etiology of different types of stroke. So we've got some lovely bread for the TOAST trial. We can have a large versus small vessel cause of stroke, okay? And in small vessel, you're particularly thinking about hypertension, diabetes, that kind of thing. The third type is cardioembolic stroke, AFib, aflutter, mechanical valves, i.e. septic emboli. There's kind of like a cop-out last two, really, which is cryptogenic, which is, in other words, idiopathic. We don't know what's caused it. And the other thing, which is the rare causes. So I've tried to sort of parse that out a bit. So your monogenic syndromes, which we love at the Walton, like CADASIL, CARASIL, Fabry's, MELAS, that kind of thing, they are your rare causes that are genetic, and fetamin use, much more common, as is carotid artery dissection, rupturings of them, and embolic states, okay, so sickle cell, lupus, antiphospholipid, cancer, active cancer is prothrombotic, remember, Virchow's triad, and autoimmunity. Cryptogenic stroke, so this is 30 to 50% of all strokes, right, are because of one thing, paroxysmal AF. Sorry, 30 to 50% of cryptogenic strokes. And so the issue here is that you clock them in, you do an ECG, normal sinus rhythm, fine, it's not cardioembolic. They've no history of mechanical valves, they've not got any infectious endocarditis, stigmata, goodbye. Here's the problem with that. A third to half of them actually have got paroxysmal AF that comes and goes, right? So we should be putting way more patients on at least overnight telemetry when we move them to the hyperacute stroke unit, and probably on that for a week, but most certainly a 30-day loop recorder on discharge. When you do that, it increases the amount of AF diagnoses five-fold. That's what the data tells us, and doubles the amount of people on DOACs. So that is a huge risk reduction strategy for a 30-day loop recorder that gets returned to the NHS. The second way we can classify stroke is over to Oxford for the Bamford-Oxford classification, and that's into anterior and posterior circulation syndromes. So I'm not going to labour these. So you've got total and partial anterior circulation, posterior circulation, and the lacunar infarcts. So TACs are your two, so you need upper limb and lower limb sensory motor one side, right? The acuity is the homonymous hemianopsia, and cerebral dysfunction, so your inattention or your dysphasia. Partial, you need two of those. Lacunar is a little bit different. It's a pure motor or sensory, and then the balancy, ataxia, hemiparesis, okay? Posterior circulation is bilateral motor, but cranial nerve and cerebellar signs as well. So the whole point that I was telling the MDT about this is that basically these are pretty typical syndromes that you can see that help you to localize the lesion, that help you to identify the kind of treatment pathway they're going to go down, which you're going to see shortly. So, we can also divide it by the blood vessel territory. So MCA is MCA, mumbling, aphasia, contralateral upper limb face, and acuity homonymous hemianopsia. Whereas ACA is abulia, which is difficult with initiation, which is your supplementary motor. So your premotor plans, your motor executes, and your supplementary motor is the starting pistol that gets it going. Contralateral lower limb, and then accidents, your urinary incontinence, if we remember, which means that we there know internal carotid because it forms the ACA and the MCA, so it's both. PCA also spells PCA, so if you just forego the P, then you've got cortical blindness if bilateral, and a contralateral hemianopsia. Okay, if it's not bilateral with macular sparing, of course. So. Interesting point about, obviously this is the brain and the spinal cord. So we've got the upper motor neuron lesion, so you would expect things to be up, right? Hypertonia, hyperreflexia, that kind of thing, and spasticity. And that does come, okay, with the lack of inhibition of your Renshaw cells, but in the first few hours to days, you can have hypotonia. So the decreased alpha motor neuron firing is seen transiently at the start of big upper motor neuron syndromes. That's when the spasticity then becomes your contractures as a consequence later. But don't be mistaken for, ooh, I'm seeing lower motor neuron findings, therefore it can't be a stroke. Don't make that mistake. The second thing is that it's very common for a cardioembolic stroke to be having an MI as well. We don't have the exact figures, but it's enough that everyone that you're querying under that TOAST criteria for a cardioembolic cause of that stroke needs a troponin. Okay, so troponin is now very routinely done in the workup. So we've talked a bit about the types of stroke and how we classify them by etiology, but what do we do about severity of stroke? So this is where we use the NIH stroke scale, and I use these 4 parts of an exam to estimate the score properly. So for hello, at the end of the bed, I asked them their age and month and then asked the nurse to kindly do BM obs and a 12-lead ECG. For their face, I'll ask them to open their eyes, close their eyes, show their teeth, and for the eyes, I'll look for a visual field defect and horizontal gaze only. You don't do the caloric testing, that's contraindicated in the stroke scale, but you can do the oculocephalic reflex. For limbs, I test all 4 limbs, sensory and motor. For motor, you do drift, so it's 10 seconds upper limb at 90 degrees or 45 degrees if they're supine. And you only assess lower limb supine. You can't assess them in a chair, so you have to get them on a gurney. You want their limb to about 30 degrees and see how long they can do that for. The only other thing that you need to add to this is your finger, nose, finger, and your heel shin test for obviously those cerebellar signs. So, cause, syndromes, definitions, severity, what's next? So now at this front door, I need to ascertain, is this a block or a bleed? Right? Are they stroking because of a clot? Are they stroking because of something else blocking? Are they stroking because there is actively bleeding into the brain case? What do we do? Everyone's favourite, we do a CT head. And if you have a look through this CT head here, which I can just scroll through, you will identify, hopefully, unless I've made a massive mistake here, that it's a normal CT head, that there is no blood. No blood. No breach to the bone case, normal CT head. So if that patient had the stigmata of a stroke, a syndrome, you'd say no bleed, so we can proceed to anticoagulation if it's within the windows. This is a patient with an intracerebral and intraventricular bleed, and intraventricular bleeds, as we're going to see, are surprisingly common. What about this scan? So this is a CT angio of the head and neck, and we're going to do that for anyone who scores a 6 on the NIH stroke scale. Okay, and that's to see if a thrombus or dissection is amenable to intervention, which is really important. A lot of people carry the stroke scale around in a little card on their lanyard, just so they can sort of not have to memorize it. which is quite useful. I have just memorized that exam that I showed you before, and then I plug it into MD Calc whilst I'm clerking. It's pretty apparent quickly in the exam whether or not it's severe enough to need, all sorts of things. But you usually have time while they've gone for imaging. Now, what about a patient who has woken up from a stroke, or you've been going down an alternate pathway or whatever, and anyway, you don't know the time, or the time is outside of the window for thrombolysis, which is 4.5 hours? Well, you can do a DWI plus minus flare imaging on the magnetic resonance brain for wake-up or delayed strokes. And what you can see here is the difference between a penumbra and a core. So this is an penumbra, so this is potentially salvageable brain tissue from an ischemic MCA, right? And then here is far too much necrosis going on here. So this is the core and the outer penumbra. So you can calculate the different ratios and fancy machine learning algorithms to determine whether or not it's worth an intervention with the MRI DWI. So this has led to a lot more people getting the interventions. We're hitting it more aggressively. So you're an SHO at the door, what are you going to do? So A2E assessment, and you're going to look at the alteplase or tenecteplase rules, which we're going to come to in a moment. We're going to ask the questions, be fast. So balance and BARF, eyes, face, arms, sensory motor, legs, sensory motor, speech and swallow issues, and a thunderclap headache, worst pain in their life, in the head, sudden onset, hitting the back of the head by a cricket bat, that kind of thing. Rule out subarach, right? The bloods, you're going to do a complete blood count, clotting, lipids, OBS and neurobs, troponin, ECG, as well as the thyroid, and then you're going to do a triple scan. So you're going to do CT head on all, CT angio, if you're thinking about thrombectomy or other things like that. You may need to do an MRI, DWI, and then the third scan to consider is an echo for all those cardioembolic sources if you're querying it. You're going to calculate the stroke scale, and also you could do a HINTS if you're looking at posterior stroke, because that's about central versus peripheral causes of vertigo. So that's important for localization. You're going to have a guesstimate about where in the TOAST criteria a stroke is and its syndromes. Then you're going to look for mimics. So mimics, think migraine and injury, head injury in particular, right? We've got meningoencephalitis, we've got an intracerebral bleed, cancer, stroke, seizure, and sugar. And then blood pressure. Blah, 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 blah. So there is a big debate in the literature and international guidelines as to how much perfusion you need and a blockage to keep that penumbra going. Most guidelines now say that if blood pressure is over 220, you should intervene with IV labetalol or a calcium channel blocker pretty aggressively. Over 24 hours, lower it by about 15 to 25%. And that's if it's a block, not if it's a bleed, right? If it's a bleed, all rules are off. But if it's below 220, without any attempt to control it medically, leave it alone. That's what most people say. If you failed the SALT criteria, that's a problem, obviously, and you should keep the patient normoglycemic throughout for really good interventions. Dual antiplatelet therapy going home, if indicated, which is for most people, and then hollowing out. So this is what we call a mechanical thrombectomy, okay? And that's if you've got large vessel occlusion, okay, up to 24 hours if your stroke scale 6 with evidence of that penumbra. So let's talk about busting the clot with tenecteplase, boom, which is our thrombolysis therapy. So it's weight-based, it's a single bolus, so you can just give it straight away, which has pros and cons. If they start bleeding, it's already given, so you can't discontinue the infusion. But it's much quicker to get it to full bioavailability because alteplase is 10% as a bolus and then you infuse for an hour. So that's the difference, okay? And it seems to be non-inferior and a little bit less likely to cause bleeding. So that's why we've moved kind of to tenecteplase. But we still use alteplase as a mnemonic for the TPA thrombolysis contraindications, okay? So A is arteriovenous malformation. Last known normal, so that should be LKN, over 4.5 hours. Trauma or an MI within 3 months. Endocarditis. If your platelets are low, if your INR is over 1.7, and there's things like PTA, PTT, all these different things, and they're kind of trust dependent. Cancer, active cancer, if you've got an active subarach or ICH bleed, intracranial hemorrhage. And if the systolic remains over 185 despite that optimal medical therapy trying to get it down, then you've got a problem. To monitor, relatively straightforward. You've got your neurobs. They should be in a hyperacute stroke unit setting or ITU, so you can't do this on a ward usually. And a CT head should be done 24 hours later, and definitely before starting antiplatelets or anticoagulation. Okay. And that's because we've got all of these rules in place because they bleed. So 6% of all people you give TPA to will bleed. So if you're on a busy stroke service, you're going to see it quite a lot. You're going to see it every week. So what are you going to do about it? So if we're managing the bleed, we think, oops. So we're going to omit the agent. If they're on alteplase, we're going to stop it, right? And call the on-call surgeons. Give platelets, fibrinogen, cross-match, whatever hematology you want us to give for that. Scan the head again, do a serial scan plan, and then keep an eye on the systolic blood pressure. Get it under control. A key rule here is you can't give tenecteplase within a day of treatment dose heparin. Okay, so the PE patient who strokes, they can't have it. It's a firm no. Now the mechanical thrombectomy, this is clot removal, okay? So MTB, mechanical thrombectomy. So in goes the balloon, stent is lifted up, and then out comes the clot. Yippee-doo-dah-day. If only life were that simple, eh? The people who can get it are a modified Rankin score, so that's a bimodal prognosis. So 0 to 2 is kind of good, and then 2 to 6 is poor. So if they have a good prognosis score, pre-intervention, if you're giving alteplase or tenecteplase, if there's a blockage of ICA, PCA, or a proximal MCA, then you can do it. So note what you can't give it to, so distal MCA, ACA, although there's a lot of trials being done on those. How distal can you go with the MCA? And they're for adults only, okay? And then they need to score 6 on both the aspect score, which is a CT head score, and the stroke scale score, as we talked about. Now, quick rules on aspirin and oral anticoagulation that you see a lot. Aspirin, you need to give it immediately if they're not for thrombolysis or thrombectomy, or the service doesn't provide it. Or within 2 days. And this is because aspirin is being used in this instance, in the acute phase, to prevent a restroke. Oral anticoagulation is about 2 to 14 days for your cardioembolic risk factors. This is usually a consultant hematology/cardiology discussion that you have. So, what about hemorrhagic stroke now? This is an interesting one. So if we're going to manage hemorrhagic stroke, we're going to use RED as our algorithm. So the regular stroke workup and reverse agents, because 20% of all these bleeds are caused by our medications that we give them. We're going to look at the etiology, and the mnemonic of that is burst pipe, so we'll come to that in a second. And we'll look at elevated ICP. We're not going to give DEX because steroids worsen outcomes with bleeds, worsen recovery and plasticity and that kind of thing. But we are going to consult the surgeons to be told on Orion that it's for local management usually, for decompression. Okay, so for hemorrhagic stroke, we're going to begin with the causes. So we've got brain tumours as the B, U is that very high uncontrolled hypertension, runny blood, so any kind of coagulopathies that you've got. AVM, structural issues and aneurysms, as well as senile amyloidopathy and CAA, those things, and sclerosis, so your atherosclerotic patients, and TBI. All these things damaging blood vessels. Here we see an intraventricular hemorrhage, and it's a lot more common than you hope it is. There it is post-mortem. Actually, 50% of bleeds move to the ventricles, and 50% of these get hydrocephalus. So it's a pretty poor prognostic indicator when you do a CT head for a stroke patient, and you see not only a bleed, always comment on extension to ventricles, because it's very important for surgeons and prognosis. As is the follow-up scan. So because there could be a ton of secondary causes for the bleed, you need to wait 6 weeks for a good proportion of that blood to clear, so you can then see what a cause might have been. Could have been a tumour that's been obscured by the hematoma, you just don't know. When we're back at home, or in rehab, or wherever, or back in stroke TIA clinic, we need to think about secondary prevention for these patients. And actually, this ties in nicely with primary prevention as well, because it's just a more aggressive form of primary prevention. So think seconds. We need to deal with a lot of S's. Smoking, substance use, like amphetamines, all that kind of thing. Statin optimization, they're going to be on the secondary prevention dose, which is much higher. And then stenosis. So if it's 70% carotid artery stenosis, they need to have an intervention within 2 weeks, depending on what the surgeons want. It could be CAS or CEA. And then at 50 to 70% asymptomatic, the surgeons will decide whether it's worth it, because these interventions are actually quite aggressive. A good percentage of patients stroke on it. So you need to weigh up the risks. And if the pros and cons, risk assessment are about 6%, they tend to intervene. Elevated BP and exercise. So there's a lot of different societal guidelines on who should be controlled, what they should be controlled. The general tentative consensus in the literature is that it's not age related for secondary prevention. Pretty much everyone 130/80. Even the oldest, frailest people tend to be okay with 130/80. Don't necessarily take my word for that, because your local society will probably disagree with me, but everyone has a different number, and I tend to think that if the guidelines numbers are all over the place, then there's a paucity of evidence, and I like 130/80. A lot of societies believe in this, and it's a nice round number. So cardioembolic and CKD, you need to optimize all of those risk factors, of course. Estrogen-containing oral contraception is a really big one, because it's prothrombotic, so you need to be really careful with that, as well as obesity and your metabolic syndromes. So good nutrition, and then migraine. So migraine, particularly with aura, vascular risk factors with that, okay? Diabetes and pregnancy. You see a third trimester postpartum, and any stressful things, psychological input. So we come to the Sid Watkins. So because this was for the rehab people, I put a bit of rehab in, but because they're a rehab MDT, I'm not going to belabor the point. So this is the Sid Watkins where we do it, and that's Sid Watkins on the left, the pioneering professor of neurosurgery in Liverpool, who did a lot in Formula One, travelled all over the world, designed helmets and seatbelts and like non-penetratable engines that wouldn't explode, and he attended to Ayrton Senna, the Formula One driver who died really tragically, and he just did amazing things, to be honest with you. So he rightfully has a building at his old hospital named after him. So the acute phase of stroke, we're going to deal, and that's up to the first week effectively, medically optimize and preventing complications, so your medical complications, as we well know, DVT, ulcers and the like, and preserving muscle and joint length as well as participation. In the subacute phase, this is a sort of this is your 1 week to 6 month phase. So this is where we're moving towards the more sort of, rehab complexity scale, levels 1, 2, and 3, with the structured MDT approach and all these intense things. For your more chronic patients, okay, these are more community, focused on self-management and ongoing structured exercise programs and the like. When we look to the future with my beautiful animation, we've got exoskeletons with robots that have low to moderate quality evidence and cost £100,000 per device. I'm not sure about the future of robots. Jury's out, but also the tech is rapidly changing all the time, and there's accelerometers and gyroscopes and machine learning for immediate feedback. Your gait was 20 degrees off this way, so the PTs are going to work with you to get this thing, and there'll be an orthosis from OT that help with assisting this, and there'll be all sorts of fancy ways in which the robots can be used as adjuncts to this approach. We're not there. Who knows where we'll be in 10 years, but it's an emerging thing, as is the brain-computer interface, where these electrodes are listening to your primary, supplementary, premotor cortices and the like, the origins of these pyramidal tracts, and helping to manipulate prostheses, which are very exciting, and they seem to be maybe a bit more further along. This fantastic picture of TCMS. This is for someone who's got depression, or it could be migraine, and we use it to change the sort of like cortical spread and depolarization and all these hyperexcitability things. It can be used as a direct current to trigger the action of the muscles, or it can be used with magnetic stimulation to sort of encourage along the motor cortices to assist in movements, and that has some sort of moderate quality evidence. It seems to be doing pretty well. In terms of virtual augmented reality, there's just great pictures. I mean, I just love it. You know, do you know what I mean? I think it's absolutely hilarious and great. It's so cool. We don't know where the tech is going with this. We don't know whether this is the future of computing, whether everyone's going to have Tony Stark Iron Man glasses. We don't know. Um, I happen to think that it might be in 10 years' time, we'll all have wearable glasses that don't look like this, but look like normal spectacles. But we have screens. Some people think that's horrendous. But if that's the case, then you could put software on patients and they could have, lots of wearable health metrics that could assist them in these things. If it does catch on, it does fit some of the pillars of person centered medicine that tends to be concordant because we have autonomy because patients get to choose their tasks and settings and pace. They can put the thing on and say, all right, it's time for another session kind of thing. They can do that at home as well and out in the community. Competence, they can get real-time feedback from the machine learning as well, which is being validated currently. And the scenarios to build utility, so it's relatable, right? You could use your phone to scan your home environment and then simulate it in the hospital. So the patient is practicing in a virtual kitchen that is actually identical to their kitchen. So a lot of this is theoretical. Where will it be? We don't know. But what we know is that it's all about augmenting the current MDT approach, not replacing it, and all about leaning into ways to develop neuroplasticity, which is quite exciting, right? So there's the team. There we all are. Me, Soph, David, Gargi, Ryan, and Lucy as well, who was the clinical observer at the time. And then my beloved mentor, Dr. Reddy. There she is. She wasn't there on the day, but she is always with us in spirit. There she is with her award. So thank you all. That's my talk on stroke for 2025, and I'll see you next time.